Hi, I'm Dr. Sam Mann, and this is Beyond Conventional Medical Thinking. The topic for this and the next episode are hypertension, high blood pressure, the area of my specialty. Over 100 million Americans have it. Majority of the population above 40 or 50 has hypertension, uh, and most are on treatment for it. It's a risk factor for heart disease, stroke, kidney disease, etc. So this is relevant to a lot of people. And please let your family and friends know about this because I'm going to give some very clinically relevant points regarding the treatment of hypertension. The good news is we have great medications. We can control hypertension in almost everybody with the right medicine. Um, and that's why it was such a satisfying specialty, because it's like you're correct 98% of the time, ultimately, uh, because of the availability of such great medication. Yet, if you look at the studies, about half the people with hypertension are not under control, either because they're not seeing a doctor, or they're not taking the medicine, or they're not on the right medicine. And we can clearly do much better. So one of the key things I'm going to talk about is the fact that many are not on the right medicine, and we'll talk about that. The talk today is about the initial treatment. What medication do you start with in a given patient? And the next episode will be what to do with people who have resistant hypertension, meaning they're on the usual medication and their pressure is still not controlled. So we're talking about the initial treatment. And I'm going to focus also on what the 2025 hypertension treatment guidelines uh, tell us to do in treating hypertension. And I think there are a lot of things they say that are right, but I also think there are some things that I disagree with. And I'm going to explain why I disagree with it and how we can do better. So in the initial treatment, the guidelines talk about a choice of three types of drugs. One are the diuretics, one are the calcium channel blockers, and the other one are the ACE inhibitors and angiotensin antagonists, which are very similar. So those are the three main categories. And the question that I ask is, okay, which one do we use? Now, the guidelines tell you, okay, let's try one. If it doesn't work, add the second. If that doesn't work, add the third. And I don't agree with that, because what they don't do in the guidelines is to tell you, well, how can you decide which one to give, as opposed to just randomly trying one, adding, and then ending up on three medicines, when in fact, if you got the right medicine first, you might need only two or even one. So we're going to talk about that. And how do you tell? Well, what is the mechanism by which the pill lowers the blood pressure? And what is the mechanism underlying the individual patient, your hypertension? And you match them. And there's plenty of research that's been done and reported that give us ways to uh, pick out the right medication, to individualize, but they don't do that in the guidelines. And that's what we're going to talk about. How do you get the right initial medication? And how do we avoid people being on three medicines when maybe they need only two or one? So, how do we improve the chance of getting it right the first time? Um, by paying attention to underlying mechanisms of hypertension. What is the cause of the hypertension in this individual? And there are different mechanisms. And in fact, there are three main mechanisms that we will talk about. The guidelines don't discuss the mechanisms. They don't discuss matching the medication choice to the mechanism. So we're going to talk about that. So there are three main mechanisms. One is sodium volume, and that relates to salt sensitivity, people whose blood pressure is high because they hold on to salt or they have a huge salt intake, and that's one. The second is the renin-angiotensin system. What a name. It's a hormonal system related to kidney function, and it when it's stimulated, it increases the blood pressure. And in some people, it's stimulated based on genetic factors or based on abnormalities in kidney function. And drugs that target the renin-angiotensin system work best as the first drug in those patients. The third mechanism is less common. It's the sympathetic nervous system. And that's our fight or flight reflex. And medications for that differ than for the other two. In this talk, which is on the initial treatment, since the first two mechanisms dominate, we're going to talk about treatment targeting those two mechanisms, which is appropriate in most patients. In the next episode, we'll talk about the sympathetic nervous system and medications targeting that. So, what are the clues to tell us which medication to try? There are clues. And the three main clues, one, race, two, age, three, a biochemical test called measurement of plasma renin activity, or for short, renin. And we'll talk about those. When it comes to race, there is a lot of evidence in the literature that in the Black population, hypertension is much more likely to be linked to the sodium volume mechanism. And diuretics are more effective than the drugs that target the renin-angiotensin system. And that makes sense. Now, why is there a difference? Not certain, but one can think about genetic factors, of course. And one important thing is if you look at evolution in populations in hot climates, tropical climates, where people sweat a lot, and it's an advantage if they're able to hold on to the salt that they take in. And remember, throughout history, you didn't have Italian and Japanese and Chinese restaurants, and all the restaurants that are loaded with salt. There was a much lower salt intake, hot climate, and those most likely to survive are those whose kidneys would hold on to salt instead of just excreting sodium as it came in, and that was a survival advantage. Of course, in an era where there's a truckload of salt taken in every day, that genetic advantage becomes a disadvantage as the body holds on to salt and contributes to raising blood pressure. In the previous guidelines, they do mention difference in race between the likelihood of the salt retention genetic predisposition. In the current one, they don't mention it. I'm not sure why, but they don't. If one is with Black patients, the likelihood is that the hypertension is salt sensitive and a diuretic would be the right first drug. The second class of medications, the calcium channel blockers, such as amlodipine, also are more effective in patients whose hypertension is related to sodium and volume, and it works pretty much equally as well as diuretics. So one could theoretically try one or the other. Certainly, if a patient has a lot of swelling in their legs, you would go with the diuretic because the amlodipine one of the side effects is retention of fluid in some patients. So those are two clues. Whereas in the Black population, you would lean toward a diuretic or a calcium channel blocker. In the white population, it's more or less even, Steven. Those and the renin-angiotensin system drugs will work equally well. Second clue is age. As we get older, we tend to hold on to sodium, and therefore, as we get older, we tend to be more responsive to a diuretic. So that's another clue. In a young patient, we'd be leaning more toward a drug that targets the renin-angiotensin system. Now, the third clue is measurement of plasma renin activity. Renin is an enzyme produced by the kidney. It stimulates angiotensin, which raises pressure. And drugs that target it are effective in people whose hypertension is driven by the renin-angiotensin system. And there are numerous drugs to pick from. The two main categories are the angiotensin converting enzyme inhibitors, and you're probably familiar with some of those. And there are a number of good ones among them. The other category are the angiotensin receptor blockers, and there is the list of those that are widely used. The losartan was one of the original ones. It's a little less long-acting and a little less effective than the others, but otherwise they're all pretty good. And there are some others, but we don't need to get into that. There's also a category for people who can't tolerate these. There are other drugs, but let's stick with this because this is what's relevant to most people. So, and we mentioned the third clue was the renin, plasma renin activity. So in those whose renin activity is elevated, these are the drugs that work. In somebody with a very low level of plasma renin activity, the diuretics and the calcium channel blockers are the ones that work better. And at Cornell, we very regularly measured plasma renin activity, and it was very helpful. And there are studies that all show similar results, that with a low renin, the diuretics and calcium channel blockers work better. With a high renin, the ACEs and ARBs work better. One problem I have with studies is that they often use a cutoff of 0.6, meaning if the plasma renin activity is below 0.6, that's low renin. Above that, that's considered high renin. That's wrong. If the renin is 0.7 or 0.8, I would not consider that high renin. You could say there's an intermediate range, and then the numbers can go high, 5, 10, even higher. So to call somebody who's 0.7 in studies and categorize them as high renin, I think that dilutes the predictive value. The plasma renin has been so helpful in helping to choose the right drugs to initiate treatment with. Unfortunately, the test is rarely used by internists, by physicians. One can ask why, and that's a good question, and it's unclear. It is of value in selecting a drug rather than blindly picking a drug without rationale for why this one or why that one is very helpful. If you have severe hypertension, they should absolutely measure the plasma renin activity. If it's somebody who's a young adult who shouldn't have hypertension, you want to know that. It's a very valuable test. As a side comment, I think the pharmaceutical industry is not so interested in the renin test because they want their drug to be given to everybody. They don't like a test that says, okay, here's the result, and that drug will not work in these patients. Don't use that to start with these patients. They want their drugs used for everybody. It's a very helpful test. Regrettably, a number of the insurance companies now might not pay for the test, might not cover it. And I think that is a shame because it is a helpful test and it's grossly underused. Now, in talking about the initial drugs, I want to make a comment about the diuretics because they're so commonly used. And here's the problem. The most commonly prescribed diuretic is hydrochlorothiazide. And way back before the turn of the century, it was one of the oldest drugs available and one of the few drugs available that was effective. And the typical dose would be up to 50 milligrams once a day. And it was an effective drug. However, the 50 milligram dose has side effects. It can cause a low potassium level due to loss of potassium in the urine, it could cause a low sodium level, and sometimes it could result in dehydration. And those were real concerns. And as new drugs began to appear on the market, the need for such a high dose was made less. And now physicians generally prescribe 25, which is safer than 50, but not as effective as 50. And in elderly patients, maybe even start with 12 and a half. So if a patient is on 25 milligrams and the pressure is not controlled, then what do we do? And the good news is that instead of going up to 50 milligrams, we now have a selection of what's called potassium-sparing diuretics, meaning diuretics that do not pour potassium out in the urine. In fact, they they reduce the excretion of potassium. They protect the potassium level. It's a beautiful combination together with the hydrochlorothiazide or the other uh, widely used diuretic chlorthalidone. So it's a wonderful combination, and we have a number of potassium-sparing diuretics available. Um, uh, Two issues about using them. One issue is if you look at the guidelines, if you give a patient a 25 milligram hydrochlorothiazide and it doesn't work, the guidelines will tell you add a calcium blocker, add a ACE or an ARB. If they're on 3 drugs and it doesn't work, then try a potassium-sparing diuretic. So what they're saying is the patient should be on 3 drugs before you give a potassium-sparing diuretic. And I disagree with that. I mean, we know that hydrochlorothiazide 25 is not that effective. And particularly if it's a patient with clues that it's a sodium volume related hypertension, why wait till they're on 3 drugs? Why not just add it to get to the equivalent of the 50 milligram dose without giving 50? If it's an older Black patient, yes, I would do that before adding one drug and another. Um, that's an important point that the guidelines say wait till they're on 3 drugs and then they're on 4 drugs when this could have been the potassium sparing drug, could have been the second drug, the first add-on. And that's an important consideration. Then the other question is which of the potassium sparing diuretics to use. And there are 4. The one that was most widely used for decades was spironolactone. It works. It can have some side effects in terms of breast tenderness, in terms of sexual function. Um, and that's a problem for some patients and not for others. But we have other alternatives. We have eplerenone, which does what spironolactone does with it's a little less effective and a little less in terms of side effects. So that's an alternative. There's another alternative, amiloride. Amiloride is a potassium-sparing diuretic that's well tolerated, doesn't have those side effects, works pretty quickly, safe, and rarely used. It's a pill that I loved prescribing because it worked and it was well tolerated. Why does nobody prescribe it? And this is an example of where the pharmaceutical industry was made an error in their marketing plans. When they developed this drug, amiloride, they decided this is when people were taking 50 of hydrochlorothiazide, and they decided to market it as a combination pill with 50 of hydrochlorothiazide plus 5 milligrams of amiloride to negate the drop in potassium, protect against the low potassium, which makes sense, except that we already said the 50 milligram dose is pretty high, and now you're adding the amiloride to it, which makes the diuretic regimen even stronger. The mistake they made is they didn't just market it as a add-on pill to be given separately to whatever diuretic. Um, and then once it lost its patent over the years, then they just did not do many studies to show how effective it is on its own. The two studies that I could find show that it is absolutely as effective as spironolactone, an inexpensive, fewer side effects, and a great add-on pill to hydrochlorothiazide or a loop diuretic. We did not discuss the loop diuretics today, and those are the drugs like furosemide. Um, there are three loop diuretics that are an alternative to the usual thiazides. Um, there are these three. The most widely prescribed is furosemide, otherwise known as Lasix. And of the three, the one I like is torsemide. Why do I like the torsemide instead rather than the furosemide? Two reasons. One, its absorption is more reliable, so you can count more reliably that the dose that you take is absorbed and working. Whereas the furosemide, it's a wide range, and a lot of people don't absorb much of the dose. Um, so sometimes it doesn't work just because they don't absorb it, and you have to go to a higher dose. And I think I said in a previous podcast, how do you judge whether the dose is effective? I say very simply, it'll make you urinate a lot for a brief period of time. And if it's working, you will know. If you can't tell if it's working, then you need a higher dose. Um, and the other advantage of the torsemide, aside from reliable absorption, is that the effect is a little longer. So whereas the furosemide is about 3 hours, the torsemide is about 4 or 5 hours. And what most doctors don't realize is if you look in the guidelines and it says how often the pill should be taken, it recommends furosemide Lasix twice a day for hypertension and torsemide only once a day. Uh, Nobody's going to take furosemide twice a day unless under duress. So that's the other reason torsemide is a loop diuretic. The newest potassium-sparing diuretic was just approved. It's baxdrostat. It blocks the effect of the hormone aldosterone, and that reduces potassium excretion and increases sodium excretion. And it's new, it's expensive. Its best use is in those whose hypertension is related to oversecretion of aldosterone. It can also be used for patients with hypertension who are on a diuretic, although it's going to be a very expensive drug. And the existing potassium sparing diuretics do the job in those patients. So for the average patient, baxdrostat is an expensive alternative that usually is not necessary. The existing potassium sparing drugs, and as I said, the one I like the most because it's the best tolerated is amiloride. They do the job. They lower the pressure, they protect the potassium. I mentioned the second category of calcium channel blockers, and familiar ones are nifedipine and amlodipine. I think amlodipine is the best seller, and they lower the blood pressure by vasodilating, relaxing the blood vessels, and they tend to work more in patients who respond to a diuretic, low renin, and by that token, it would make more sense if you're going to combine two of the three drug categories. We said diuretic, calcium channel blocker, and ACEs and ARBs. Makes more sense to combine a diuretic with an ACE or an ARB or a calcium channel blocker with an ACE or an ARB rather than a calcium channel with a diuretic as your first choice combination. You can add it. There could be some additive effect, but not as much by adding those two. Next, the drugs that target the renin-angiotensin system, the ACE inhibitors and the ARBs. These are the names of widely used ACE inhibitors, and they're all pretty much equivalent. Vasotec, the enalapril, might not last 24 hours. The others do. And one can choose from them. The angiotensin receptor blockers, they're all pretty equivalent. I'd say the first one, the losartan, might not last for 24 hours and is a little weaker than the others. The others are pretty equivalent. The most potent one is azilsartan, a DARBI, and the studies show consistently that it does lower pressure on average more than the others do. So sometimes in somebody whose hypertension is not controlled on the three drugs, switching from the other ARBs to the azilsartan can sometimes make a difference. As a newer drug, it was more expensive. And in most patients, probably the response is the same, but there are some patients who get a response who didn't respond to the others who do respond to the azilsartan, so that's also an option. Finally, the guidelines tell us that if your blood pressure is above 140, they recommend starting with a combination pill. So that could be a diuretic with an ACE or an ARB. Most of them are that combination. So they recommend starting with two drugs, and clearly the combination of two lowers the pressure more than starting with one or the other. On the other hand, if it works, it means you're going to be on two drugs, possibly forever, not knowing if one drug might have done the job. So, for example, if it's somebody who has a low renin, and the diuretic might have done the job by itself, but they're now on an ACE or an ARB with it. And in the individual patient, you just don't know if the second drug is contributing or is just along for the ride. So my concern is I'm reluctant. If the pressure is 150, 160, it makes more sense to try starting with two. But for pressure just above 140, if it's a patient who's reliable and follows up, I think it's reasonable to start with one drug. On the other hand, if it's a patient who is not isn't seen regularly, it may make sense to start with two. There's a better chance of getting control. So we're going to stop here. If you have any comments or questions, my website is drsamuelmann.com. So the next podcast goes to the next step, resistant hypertension. You've done the three drugs and it doesn't work. It doesn't control the blood pressure. It's resistant hypertension. What are the steps you can take? And I have some comments in which I disagree with the guidelines, and also a very effective option for resistant hypertension that's well tolerated, widely available, that is not even mentioned in the guidelines. And we'll talk about that part 2 of this podcast on the pharmacologic treatment of hypertension. Thank you.